Welcome to this presentation of new interRAI research published as part of the Frontiers in Psychiatry special issue on innovations in the mental health applications of interRAI assessments. My name is Keir Johnson from Doctors Manitoba, and I will be the moderator for this session. Today's presentation will include two interRAI researchers who collaborated on a paper entitled School Disengagement and Mental Health Service Intensity Need among clinically referred students utilizing the interRAI Child and Youth Mental Health Assessment Instrument. We will begin with a brief presentation by Dr. Janell Klassen. Dr. Klassen is a psychologist working in the community who recently earned her doctorate degree in school and applied child psychology from Western University in London, Ontario. Dr. Klassen's research investigates children's mental health utilizing the interRAI suite of assessment tools, and she has recently published her research investigating school, disengagement, and mental health among young people. Dr. Klassen has contributed to several interRAI instruments and supplements throughout her graduate education. She will be joined by Dr. Shannon Stewart, professor and clinical training director at the Faculty of Education and an adjunct assistant professor within the Department of Psychiatry at Western University. She's an associate scientist at the Children's Health Research Institute and associate scientist at the Lawson Health Research Institute. Dr. Stewart is an interRAI fellow, lead developer, and international lead of the interRAI Child and Youth suite of instruments and has published extensively in the area of children's mental health. We will provide a web link to the articles in the special issue at the end of today's webinar. Dr. Klassen, I'd like to turn things over to you for your presentation.
Thank you for the introduction. The first onset of many mental health issues is typically between childhood and early adulthood. Approximately 20% of Canadian children and youth experience significant mental illness with clinical impairments in their functioning. These young people often experience challenges with emotional and behavioral regulation, problems with self-care and independence, interpersonal difficulties, and school problems, such as poor academic achievement, school disengagement, school refusal, and ultimately school dropout. Notably, treatment for behavioral, emotional, and substance use problems has been linked to a reduction in negative outcomes, such as chronic mental health difficulties, conduct and delinquent behaviors, criminal justice involvement, and school dropout. However, it's estimated that up to 75% of Canadian children and youth with mental health challenges do not receive the required mental health services in order to prevent life course persistent and chronic issues. Certainly, determining the intensity and nature of mental health services required to support a young person and his or her family is a difficult and yet critical step to reduce the likelihood for the manifestation of distress. Challenges exist in mental health care for young people across Canada with respect to access to timely and effective treatment, as well as in the coordination of these services across sectors. We know that individuals are more likely to seek services when the problems are more severe, including the presence of comorbidity, or when challenges are experienced across settings, so at home, at school, at work, or in extracurricular activities. The education system is uniquely situated to identify and support children and youth who are experiencing mental health distress and functional limitations. Not surprisingly, the school is also revealed to be the main point of entry into mental health services for young people. Further, mental health service utilization tends to increase in early to middle childhood, stabilize, and then increase again in early adolescence. Notably, externalizing behaviors were most predictive of service use in middle childhood. However, combined externalizing and internalizing behaviors predicted service use during adolescence. School disengagement, or a student's lack of involvement in education through interest, curiosity, motivation, and active participation, may be an indicator of underlying mental health issues. The current study presents a first look at the association between service intensity need and school disengagement among clinically referred students. Second, the reason for referral to mental health services was investigated as related to school disengagement in order to offer insights for triaging purposes within the educational and mental health settings. Archival interRAI Child and Youth Mental Health data, including 14,750 clinically referred students who access services at one of the participating community mental health agencies across the province of Ontario, were utilized for this study. It's important to note that data collection was completed from November 2012 to May 2019, so before the COVID-19 pandemic. The Child and Youth Mental Health Assessment Tool is a comprehensive mental health needs assessment comprised of about 400 items that are designed to identify clinically relevant elements pertaining to the specific needs of school-age children and youth. This assessment was completed at intake into clinical services and is part of typical standard of care. 2 specific measures were used, the school disengagement scale, as well as the resource intensity for children and youth algorithm. Our total sample was comprised of English-speaking male and female children and youth who ranged in age from 4 to 18 years old and who were formally enrolled in schooling at the time of the assessment. Our data analyses first included frequencies and descriptive statistics for all variables. Next, bivariate analyses were conducted to determine the independent associations between school disengagement and service intensity needs with age, gender, and reason for referral. And finally, multivariate binary logistic regression modeling was conducted to examine service intensity need as a function of school disengagement, reason for referral, and demographic variables. Overall, we found that more than 25% of clinically referred students were at heightened risk for school disengagement and required high-intensity services. That is, individuals with comorbidities and/or functional challenges across settings, such as at home and at school, required higher intensity services than those experiencing less severe challenges. Indeed, students who were disengaged in school were between 2 to 4 times more likely in odds to require high-intensity services as compared to low-intensity services. With respect to school disengagement and service intensity need as related to specific referrals to service, overall, referral for general psychiatric symptoms increased the likelihood for high-intensity service needs by just less than 2 times for all age groups. Referral for harm to self increased the likelihood for high-intensity service needs by 5 times for youth, 2 times for children, and 3 times for young children. Referral for harm to others increased the likelihood for high-intensity service needs by 4 times for youth, 3 times for children, and 6 times for young children. And referral for addiction, which was only examined for youth, increased the likelihood for high-intensity service needs by 2 times for these young people. The current study extends the previous research to highlight the relationship between school disengagement and mental health service intensity need among clinically referred students across elementary and secondary school. Indeed, 1 in 4 clinically referred students were found to be at risk for school disengagement and requiring high-intensity service needs. As expected, findings indicated that students who require low-intensity service needs were more likely to also be engaged in school. And conversely, those who required high-intensity service needs were more likely to be disengaged in school. As expected, findings indicated that the specific reason for referral was uniquely related to the likelihood that students experienced school disengagement. Notably, harm to self and others, as well as addiction, represent forms of maladaptive coping, which in this study were found to increase the likelihood for school disengagement for all students, as well as an increase in the likelihood for intensive service needs. This research highlights the necessity for early identification and providing timely access to intervention as a method to improve the lives of those at risk for mental health and school problems. Although school staff are uniquely positioned to support students through early identification and referrals to school and community level supports, universal screeners are needed to improve the accuracy of identifying students who are exhibiting subclinical and moderate levels of distress within the classroom before high-intensity services are required. Many mental health supports and treatments are provided within the education system. However, as mentioned, the education system is not an appropriate venue to provide all types of treatment in order to address psychopathology. Thus, it's critical that sectors work together in supporting children and youth in their approach to mental health screening and assessment, which will foster improved mental health and well-being of young people. The implementation of a standardized assessment to intervention system within the education system, such as the interRAI Child and Youth Mental Health Assessment Suite, could ultimately improve our mental health delivery system in Ontario. Thank you.
Thank you very much, Janell. The paper showed that high-intensity service needs and school disengagement are associated with each other. And I think there's a natural question here about whether or not there's a causal relationship between the two. So does one cause the other, or are they both caused by some other third factor?
The current study utilized bivariate and multivariate analyses to investigate a cross-sectional archival convenience sample of children and youth. So unfortunately, causation cannot be determined from this research project. However, moderate associations and increased likelihood and odds were revealed for the relationship between school disengagement and high service intensity needs. So what that means is students experiencing school engagement problems were more likely to require high service needs as compared to those students who were engaged in school. So it's likely that school disengagement and high service intensity needs are caused by multiple similar factors rather than one specific third factor. So for example, in another paper investigating school disengagement among clinically referred students, it was revealed that school engagement problems were predicted by medical problems, internalizing symptoms, externalizing problems, sleep problems, low individual strengths, and interpersonal problems. Similarly, high intensity service needs is based on an empirical decision support algorithm that's made up of 25 individual items, 3 scales, and 2 decision support algorithms from the CHIME assessment. And these all encompass mental health symptoms, interpersonal skills, and indicators of risk. Therefore, multiple similar factors associated with a student's overall functioning or measure of well-being could be the third factor linked to both school disengagement, high service intensity needs.
Thank you very much. Your sample draws from a population receiving child youth mental health services. And I wonder, how might the relationship between school disengagement and mental health or behavioral indicators differ in the general population?
As noted in previous literature, individuals with higher intensity symptoms and greater functioning impairments observed across settings are more likely to access mental health treatments. So overall, we anticipate that young people who are not treatment seeking would be less likely to be disengaged in school than those who are treatment seeking. Now, it's important to consider that in our study, we examined treatment seeking youth, and about 20% of children and youth experience significant mental health problems, but only about 1 in 4 of these young people actually have access to treatment. So that's only about 5% of the population. So this leads to one of the key clinical implications in this study, in that early intervention and prevention opportunities to support a student's well-being are important for reducing the likelihood for manifestation of acute or chronic distress. For those students who are not able to access mental health treatment, a well-equipped education system may be able to support or even prevent these young people from slipping through the cracks of the currently siloed children's health and well-being sectors in Ontario. So what's really important here is continuity of care across sectors, so namely education, mental health, and medical health services, as it's essential for ensuring that children and youth demonstrating mental health challenges are provided with appropriate services in a timely manner.
Thanks, that makes sense to me. What do your results say about how the school system responds to situations where there is a risk to the student compared to a risk of harm to others? Are both issues considered equally important in schools?
So both harm to self and harm to others are equally important within the education system, because these behaviors represent maladaptive coping, and they're associated with increased long-term negative outcomes. As mentioned, this research highlights the necessity for early identification and providing timely access to intervention. And that's the best way to improve the lives of those at risk, whether it's the individual or those near or around the individual. So many mental health supports and treatments are provided within the education system, but as noted, the education system isn't the best place to provide all types of treatment. So it's critical that these sectors are working together in order to appropriately screen and assess young people, and in order to maximize the reductions in the negative outcomes that might otherwise be experienced.
Thank you very much. I'd like to bring in one of your research collaborators, Dr. Shannon Stewart, into the conversation. Welcome, Dr. Stewart. I'm wondering if you could speak a little bit about the broader program of research interRAI has undertaken with respect to mental health in the school system.
Sure, thanks very much. As Dr. Klassen had indicated, schools are really the first point of contact for children who are struggling with mental health issues. And within Ontario, mental health and addiction nurses have been placed in schools to support students as part of triaging and prioritization, as well as identifying needs. These nurses have implemented both the interRAI Chime screener as well as the interRAI Chime. And this provides an opportunity to foster improved communication across the service sector. It also allows the opportunity to facilitate transitional care across communities. And in addition to that, the interRAI education instrument is actually in the pilot phase, and it was specifically designed for schools for both screening as well as comprehensive assessment in relation to mental health, as well as developmental disabilities and learning issues across the educational settings.
Thanks. And for those of you out there like me who aren't familiar with all of the interRAI acronyms, of which there are quite a few, CHIME is the Child and Youth Mental Health suite of assessments. Correct, Shannon?
Yes, that's correct. Sorry.
That's okay. I slip into abbreviations all the time too. So just thinking about your response to that question, what are some tangible interventions that schools could use to manage the risks associated with child and youth mental health needs based on your research?
Well, actually, the interRAI Child and Youth Mental Health Instrument has a variety of different care planning algorithms. They're case finding methodologies that we utilize that actually trigger particular types of care plans based on the individualized needs of the children. And so, as part of the assessment system, what they provide essentially is care planning with respect to individualized, tailor, evidence-based that identifies strengths, needs, as well as preferences of children. And embedded within the assessment system is the education CAP, which is the care planning protocol. And it's specifically designed to identify children and youth who are at risk for school disengagement. So interventions are recommended and implemented based on specific barriers in educational success to reduce future risk, as well as to improve academic competency. In addition to that, it actually supports the student school network in the area of education so that others can facilitate improved outcomes for those particular high-risk children. And a multimodal approach is what we really suggest, because this type of intervention is the most successful in terms of implementation.
Thank you. So the results of this Canadian study included a Canadian sample of children and youth. And for those watching outside of Canada, they might be wondering if these results are applicable outside of Canada based on your experience and knowledge.
Mm-hmm. I believe they certainly would be generalizable to other countries with similar education structures as Canada. However, there's unique differences that occur across countries and cultures where extreme poverty or human rights issues are major issues. And in such countries, educational opportunities are limited for certain subpopulations, for example, girls. And school disengagement in these situations is much more a complex systemic issue that impacts school disengagement that Canadian educational systems may not have suffered from.
Another thing I noted about the study sample was that it drew on data collected between 2012 and 2019, as Janell mentioned in her presentation. So this was, of course, before COVID-19. During the pandemic, we've heard a lot about how school and in-person learning is so important for children's social and mental well-being. And so I wonder if you have any thoughts about how the results of this study might have changed if it had been conducted during the pandemic.
That's an excellent question, because COVID-19 has resulted in huge numbers of lockdown, inconsistent structure with respect to school systems. And so I'm sure that it has, because of the fact that students have not had the support systems, and online learning has not given them the consistency and structure that they really required. And many of these factors actually support resilience in children, such as sports, extracurricular activities, school events that facilitate a community. And disruptive routines like this and lack of structure themselves are extremely stressful for students and likely to impact school disengagement. And so teachers are also less likely to pick up the nuances of school disengagement. They're less likely to be referred for school mental health services because of this very issue of not having eyes on the child or on the student. And in North America, we provide continuum of mental health services in schools. And those who utilize those most often tend to be lower income neighborhoods. And so there's a real equity issue and differential impact with respect to school disengagement, I suspect. The other issue is many students may be in unsafe homes or may be exposed to abuse and domestic violence, and we don't have the circle of adults in which we would be able to identify these key markers and factors associated with it. So I believe that there is going to be a significant impact, and as part of future research, what we're hoping to do is evaluate that very issue, since we have data pre-pandemic, during the pandemic, and hopefully once we're out of it, or during an endemic, we'll be able to really investigate what the impact of COVID-19 has been on school engagement.
Thanks. That's a great segue to a question I'd like to bring Dr. Klassen back in on, and that's what the next steps of this research might be. What would you like to see pursued as next steps in this area?
So we absolutely want to look at school disengagement longitudinally. So with our data sample right now, we just looked at cross-sectional data points, but it would be quite helpful to look at from kindergarten through elementary, middle school, into secondary school, to see, what services were these young people provided with, and what did it do? How did it help them to remain in school, and what happened after secondary school? Did they go on to post-secondary or into the trades or right into the workforce? Another piece is racial and cultural information wasn't actually obtained in the current study. And so moving forward, we would like to examine these variables with respect to service utilization, just to see if there are any differences based on location and possibly belief systems.
Thanks. And Shannon, did you want to expand on that at all?
Sure. I think we're in an ideal position to be able to investigate, as I said before, issues around the pandemic and being able to track school engagement and school disengagement, because as Dr. Klassen had previously indicated, it has a huge impact on our community in terms of unemployment, criminal activity, as well as, long-term negative sequelae. So it's really important that we try and do everything we can to ensure that our young individuals get the best educational opportunities possible, because ultimately that really does predict long-term wellness and long-term improvement over time into adulthood.
Thank you. And one final question for both of you. As you were presenting, I was thinking about teachers in schools who have, varying degrees of awareness and background in the issue of recognizing mental health issues among their students. And I was thinking about research from another corner of interRAI around assisting police officers in the field with the brief mental health screener. And I wondered if there was potential for something like that in the education sector.
So we do have a brief mental health screener, and it's called the Child and Youth Mental Health Screener. And so it does provide information to agencies as well as the school system in terms of acuity level as well as risk level associated not only with difficulties related to academia, but also mental health and learning issues, and those kids who are at heightened risk for criminal activity with respect to policing. And it would be a great synergy to connect the brief mental health screener for kids who are at risk in the community that are being picked up by policing to support that transition and try and remain vigilant about ensuring that these children get their best education possible to try and circumvent later criminal activity.
Well, thank you very much, both to Dr. Janell Klassen and to Dr. Shannon Stewart for your research on this very important topic. I really look forward to seeing future developments in this area and the longitudinal approach, before, during, and after the pandemic that you mentioned. Thank you very much for watching this presentation on interRAI's research in mental health and addictions. If you'd like more information about this and related work, please contact us at info@interRAI.org. That's info@interRAI.org. Thank you.
To see all the articles in the special issue of Frontiers in Psychiatry, please visit the website shown here, or click on the link posted below this video. Visit the interRAI website at any time to view new presentations on this special issue as they are posted.